Realize.
Good morning, everyone. I'm Dr. Aarti Heda, the session host for this session. I welcome you all to IOC 2024, the fourth International Ophthalmic Conclave Conference hosted by All India Ophthalmological Society. Here we are beginning to a session which is going to be very interesting, cutting edge aesthetics. So it's my honor to introduce Dr. Milind Nayak, who really needs no introduction. He's consultant at LV Prasad Eye Institute in Hyderabad. He has done his orbital-facial fellowship from UCLA. He has around 230 publications in peer-reviewed journals. He has won AIOS Senior Achievement Award in the year 2015. He is on editorial board of Journal of Craniomaxillofacial Trauma and Reconstruction, Korean Journal of Ophthalmology, Orbit, Indian Journal of Ophthalmology, Journal of Cutaneous and Aesthetic Surgery. He has been Vice President of APSO PRS from the year 2010 to 2012. Over to you, Dr. Milind.
Yeah, good morning, good evening, good afternoon to everyone. Thank you, Aarti, for the great start. And I would begin by introducing my moderator, Dr. Kasturi Bhattacharjee, who again needs no introduction. She's the Director of Clinics and Academics at the Shankar Dev Nethralaya in Guwahati, India. She has a Harvard graduation in Leadership Medicine, double FRCS in Ophthalmology, and is the recipient of more than 42 national and international awards, over 75 publications, and on the editorial board of INET and AAO. She is the president-elect of the Asia Pacific Society of OPRS, and presently the vice president of our society, the Oculoplastics Association of India. So welcome, Kasturi, and I'm aware that you are traveling at this moment. But
Thank you, Milind. Thank you so much.
Around as long as you can. So we have great speakers for this session. I would like to begin by thanking Dr. Santosh Honawar, Namrata, and the AIOS for organizing this wonderful global webinar on all specialties and giving one title of periocular aesthetics to us. So we have speakers from 3 continents, starting with Deepak Ramesh, who is into private practice at New Jersey. He's a research faculty at Wills, and he did his oculoplastic fellowship from UCL. Our next speaker is going to be Natalie Homer. She's done her ophthalmology residency from Harvard and the oculofacial plastic surgery fellowship from Austin with Tanuja's group, the TOC Eye and Face. She is a fellow of the American Association of Cosmetic Surgery and currently is the associate professor at the Byers Eye Center in Stanford. Our third speaker is Tanuj Nakra, who is not a new face at all to the Indian community. He's a triple board certified facial and oculoplastic surgeon, education from Washington University and UCLA. And he's been in Austin with the TOC Eye and Face since 2008. And he's also the program director for the AACS Facial Cosmetic Surgery Fellowship and the preceptor for the ASOPRIS Oculofacial Fellowship. He has over 60 publications, and he has served on the executive committee of the American Board of Facial Cosmetic Surgery and board member of the Cosmetic Surgery Foundation. He's also co-founder of Avya. This is a skincare brand which blends science and Ayurveda, which is very well connected to its roots in India. Our next speaker is from London, Dr. Rachna Murthy, who is an oculoplastic, aesthetic, and reconstructive surgeon practicing at the Harley Street, the famous Harley Street in London. She did her MBBS from Imperial College and then ophthalmology residency at Cambridge University. And she has oculoplastic fellowships from the Royal Victorian Eye and Ear in Australia, then Moorfields Eye Hospital, and also Chelsea Westminster Hospital in London. She's currently an NHS consultant, Cambridge University Hospital, and East Suffolk. Dr. Kyungin Woo from Seoul, Korea, is a professor at the Department of Ophthalmology, Samsung Medical Center, and she is also currently our president of the Asia Pacific Society of Ophthalmic Plastics and Reconstructive Surgery. Welcome, Dr. Wu. We have a great spread of panelists, and we begin with Alice Goh, who's from Kuala Lumpur, Malaysia, ophthalmology residency from the National University in Malaysia, oculoplasty fellowship from LV Prasad here in India, then Samson Medical Center and Jules Stein Eye Institute. She's the medical director of V Specialist Clinic and focuses on eyelid and aesthetics. It's an honor to introduce Dr. Amy Shah, who did her residency from Vanderbilt Medical University, Nashville, fellowship from Stanford University, Palo Alto, and her current position is an assistant professor, oculofacial plastics and orbital surgery at the Mayo Clinic. Amy has been recently added to our OPAI as a member, and I welcome Amy. Our very own Sabrina Shah Desai from London, aesthetics and ophthalmic plastic reconstructive surgeon. She's the director of the Perfect Eyes Limited, founder of the Oculofacial Aesthetic Academy, and CEO of Dr. Sabrina Limited. She has done a fellowship from Moorfields Eye Hospital, London, and she has been my teacher for ever since I was a fellow here, as well as while she is in London. Shubhra Goel, again, needs no introduction. She's a ophthalm graduate from KM Hospital, Mumbai. She did her fellowship in ophthalmic plastics and cosmetic surgery at the Shankar Nethralaya, Chennai, and also the University of Wisconsin. She's a consultant at the Apollo Hyderabad and also runs her private practice. She's the CEO of the Clinic Cafe, which is her very own creation. She's also the director of Foresight Private Limited. So with these introductions, I think I would go ahead and invite our first speaker, Dr. Deepak, to talk about periocular fat transfers.
Perfect. Well, thanks, Milind, Kasturi, and everyone in the team for inviting me. So happy to be here. I would love to talk to you about periocular fat transfer. So let's jump straight to it. We'll talk about indications, technique, and then complications. So why fat transfer in the periocular area? I tried to use photos of patients of Indian origin from my patients because obviously the ethnicity has a huge role to play in what we perceive as ideal aesthetics. So when we talk about what makes a beautiful eyelid, especially in an Indian origin patient, a lot of times we talk about a defined upper eyelid. It's full, it has a sharp crease, and there's a nice tarsal platform without redundant skin folds.
Sorry to interrupt, Dr. Deepak.
Yeah.
Am I seeing it on presenter's view, or is anybody else also seeing it?
Yeah, if you can.
Yeah, even I see in presenter's view.
Yes.
Is that better?
It is still on the, I think you need to just end show tips and swap displays, right? Can you just use that option and see?
I have to do what? I'm sorry.
Sunil, you're there? So you see, when you put your presentation on, it is going to the presenter's view. Yeah.
Better?
Yes.
Yeah,
Yeah,
it's
it is better.
Got it.
Yeah, for sure.
Yeah, okay. I have two screens going on, so I didn't realize that was the issue. Perfect. Okay. So
yeah, sorry for the interruption.
yeah, no, thanks for letting me know. So a beautiful eyelid. Again, I was saying a defined full upper eyelid, sharp crease, nice platform, a nice short lower eyelid. So there are studies that talk about age and longer lowered eyelid length. So the shorter the eyelid is, the more youthful it looks. And then, you know, some of this is a little bit of personal aesthetic preference, but I like to think of the youthful lower eyelid as having a little bit of concavity from the medial canthus down to where the medial limbus starts. That concavity kind of shows that above here is the eyelid and below here is the cheek. And then lateral to that point, I like there to be really no definition. I like that line to be completely effaced. So really an imperceptible transition between the eyelid and the cheek. So again, you know, a nice concavity here and really imperceptible definition here that appears to a lot of patients to be, you know, a nice, youthful, beautiful lower eyelid. So, you know, I think a lot of us would agree that subtractive lower blepharoplasty is not really that rejuvenating of a procedure. You can make the patients look less puffy, but you don't make them look less youthful if you just cut the fat out and throw it away. And you end up with a lot of hollowness along that inferior orbital rim, and you still have a really long lower eyelid. And this patient doesn't necessarily look more youthful, she just looks less puffy, which there are better ways to do surgery. So two of those ways are volume preserving techniques. So on the left, we have fat transposition, which when I was a fellow, we used to do every lower blepharoplasty case as a fat transposition case. And on the right, we have fat excision plus periocular fat transfer, which is taking fat from somewhere else in the body and putting it in the periocular area. And I really migrated my practice to being 99% fat transfer rather than fat transposition. So why did I change? When does fat transposition fail? There are certain anatomic considerations where fat transposition may not be the best procedure. So inadequate donor site. You have to have enough lower eyelid fat to blend into the cheek to give you a nice result. Negative vector, or for that matter, extreme positive vector. So if the orbital rim is really far behind the globe or it's really far in front of the globe, the pedicle has a large distance to travel and it's not going to make it down in a way that's aesthetically pleasing. And finally, again, it's a matter of personal taste. If you're trying to build a particular eyelid shape for your patients, if you want to have this little concavity here and then really no transition or demarcation between the lid and the cheek out laterally, then transposition is not the best procedure, because when you transpose fat, you're taking the medial and central fat and you're bringing it straight down. So you're going to efface the medial tear trough, but you really don't have much in a way to address the lateral area, because it's quite hard to transpose the lateral fat pad. It's a smaller fat pad. It starts from deeper inside the eye socket and it doesn't mobilize as much. So for those reasons, I prefer fat excision with fat transfer, and you can really get some beautiful results in these challenging anatomic considerations like you can for these patients and still build that really nice eyelid shape that you want. Other reasons why I choose to do fat transfer instead of fat transposition: I feel like it's quicker, there's less post-op swelling because you're not doing that mid-facial dissection, and when you're doing revisional surgery. So when fat transposition fails because of anatomy, you end up with a result like this, where you've reduced the lower eyelid fat, but there's still a demarcation because the fat pedicle is not able to blend all the way with the cheek, either because there's not enough of a pedicle, or the pedicle is not able to move all the way down, or the cheek has descended. So this is a patient who was sent to me by another surgeon who's a really good surgeon who does a lot of fat transpositions, but this patient anatomically was not the best candidate for that particular procedure. So to Revisor, I removed these residual pedicles and then I grafted fat, and here now you have a better result. You've effaced that inferior orbital rim hollow, you've built the eyelid shape that you want, and the patient's much happier. And this is just another example of that, where, you know, residual pedicles or pedicles that are not able to blend into the cheek have to be addressed surgically. So how do you do fat transfer? You can take fat from a lot of different places. You can take it from periumbilical, from the side, from the inner thighs. Men, I tend to take it more from the side. Women, I take it periumbilical or inner thigh. It's just based on how soft that fat is. You have to remember that the fat retains some of its properties when you transfer it to the face. So you don't want fibrous fat, you want soft, smooth fat that's very flowy. You inject tumescent anesthetic. I inject with a 60 cc syringe. It's not powered, I inject manually. And then when you harvest, I also harvest with a 60 cc syringe with some sort of suction locking mechanism. And that really has made my speed of harvest much faster. There are a lot of different devices that will allow you to do this. And then separating the fat into its individual components. So older techniques used to centrifuge. I feel like centrifuge damages the fat cells. It reduces the viability of the fat cells. It's controversial, but as you can see, my scrub tech, I hand off the syringe and he just sets it down to gravity. I finish the rest of the bleph, and by the time I'm done, the fat has separated and I really don't need to traumatize the fat by putting it through a centrifuge. Here, I really make sure that we only keep the good stuff. So we get rid of the stuff at the bottom and we don't use any of this yellow at the top. We really just take that middle 50%, which is the good, healthy, viable fat cells. The tulip fat transfer set is fantastic. It has a lot of different parts. These are 3 different micronizers. I like the 1.2 millimeter fat sizer for the periocular area. You can use the bigger ones for other parts of the face. And that will size the fat particles into a nice smooth slurry that are still living fat cells so that you can graft them without having lumps, bumps, and contour irregularities. We're not going to discuss nanofat here because that's a whole different topic. And you inject it just like you inject filler. So if you know how to inject filler with a cannula, you know how to inject fat. You stay deep, you inject when you withdraw, and you don't inject against pressure. So, this part is not complicated, and you guys are very familiar with that technique. What happens when fat transfer goes wrong and how do you deal with it? So this patient has been referred to me because he had lumps and bumps after fat transfer with another surgeon. You can see on the right lower lid, he still has some native lateral fat remaining. And then this bump, which doesn't move with the eye movements, is the grafted fat because it's not sitting in the orbit. It's actually sitting inside the orbicularis muscle. So the way you remove that is, transconjunctivally here, I'm getting rid of that residual lateral fat pad here. And then you spread the orbicularis muscle apart bluntly, and these fat particles that are the grafted fat are easily visible within the fibers of the orbicularis. You just have to be careful not to destroy the horizontal fibers, blunt spreading, and you can take these fat particles out. Younger patients with thick skin tend to do fine. When you revise these fat lumps, they can have a really nice result. Older patients who have very thin skin or who've had a lot of trauma to that area, a little bit more difficult to revise, but you can still make them better. And probably I would laser this patient after she's healed from surgery. Once or twice a year, I have someone who feels like they've had a good result with fat transfer, but this patient told me, I like how I was at 6 weeks when I still had all this facial edema. Can you put more fat in my face? So again, this is her post-op month 3. This is her 6 weeks. She likes all this fullness. So in office, I topped her up with another couple cc's of fat, and she was happy with the result. So overall, as long as you inject with good technique, you don't inject against pressure, you can avoid lumps, bumps, and contour irregularities. And on the flip side, a couple of times a year, I have to add some more fat to someone. It's not as big a deal as taking someone back to the OR to revise transposed fat pedicles. So I like the complication profile of fat grafting better than I do fat transposition. And just as an aside, fat transfer also works really great for the superior sulcus. It works great for the rest of the face. And it's also really nice when you're doing other facial rejuvenative procedures because it cuts down on your operative time and you can still put fat in all the places that you need it. So again, thanks Milind and Kasturi for inviting me. I'm happy to talk about a topic that I really enjoy.
Thank you, Deepak. I'll now invite Amy Shah, our panelist for this talk, to initiate the discussions and her comments.
So as we wait for the chat to come through, Dr. Deepak, that was an amazing talk. I personally don't do a lot of periorbital fat transfers, but I'm familiar with the techniques. I have largely relied on fillers. How has this impacted your practice? How do you feel about filler versus autologous fat transfer? And I have a few other questions that can follow these.
Yeah, I hate filler nowadays. I'm barely using it anymore. I use it in young patients who don't need surgery, but usually I tell them to go to their dermatologist because I really just hate putting it in. I hate the hand holding of doing it in the office. I just don't like the experience. So nowadays, even if someone, doesn't need surgery, a lot of times in office, I'll still do autologous fat transfer because you can fill other areas of the face and you can use 10 cc's, 20 cc's and not go over budget for them because 20 cc's of filler is very expensive. The other thing I'll say is that autologous fat, is for the most part permanent. And even in premenopausal women, as long as you limit the volume of fat that you use and you tell them that as they go through pregnancy and menopause, they may have small variations in the fat volume and they understand that, I think it's still safe to use. It's not like the old days where people were putting 10 cc's in the lower lids. So.
Thanks for that. My other question to follow that was, we know that adipocytes also contain a lot of adipocyte stem cells. In your experience or in your observation, do you think that transfer of fat to the face has changed anything else, like rejuvenated the dermis and thinner skinned patients, or like, are you seeing any pleiotropic effects of fat transfer?
Yeah, so I didn't touch on this, but when you process the microfat into the different sizers, you can further process them with a nanofat system. So you get something called stromal vascular fraction, and that has just the stem cells, and it's not living viable fat cells. It doesn't give you volume, but it does give you those rejuvenative effects. It's great for scar tissue. It's great for, pores and skin texture, and that's injected subcutaneously. It's a different technique, but it works in conjunction with these fat transfer techniques that I discussed.
And if I can ask one more question or maybe just a comment, you've really intrigued me on pursuing periocular fat transfer. So thank you for your amazing lecture. I was curious, have you played around with different matrix within your fat transfer, like adding PRP or exosome or even fibrin glue? We know that from some studies, fibrin glue actually increases the lifetime of some of these adipocytes and mesenchymal cells that are um, in the syringe. So I was just curious what your thoughts were.
Yeah, I think the key to doing successful periocular fat transfer is to be predictable. And right now, I feel like my results are predictable by minimizing how much I mess around with the fat. So I harvest, and the time of harvest to the time of reinjection is probably less than 15, 20 minutes. And the fat is not processed in any other way apart from gravity and then the sizer. So, you can do PRP, but it's also easy to do that separately as a separate injection. And I hesitate to do too much to the fat and then end up with, variable results.
Amazing. Thank you so much for answering my questions. If there are any in the chat that I've missed, please let me know.
Aarti, do we have any questions from the audience yet?
Not yet. Not yet. I'm keeping an eye on it.
Okay. Any of the speakers or panelists have questions for Deepak?
I have a question, Milind.
So,
Can I?
Shubhrata.
Yeah, go ahead,
Dr.
Shubhra.
Kaur.
Hi, Deepak. Wonderful talk as always, and very beautiful results. I have just question, and I've seen the plastic surgeons while doing the fat transfers in the periocular area. Most of these patients do come back with persistent lymphedema, and that stays up to 6 to 8 months as well. Now we understand that could be the plane and the technique which has been used, but what is your experience on that? Have you seen these cases, and what's your treatment modality?
I guess I would ask you, are those patients also having facelifts or arcus marginalis release or retaining ligament release at the same time? Because I find that mid-face dissection or release of the ligament and blunt dissection of that area tends to more likely cause lymphedema than just injecting fat, because just like with filler, you're injecting fat with a cannula, and if you're doing lower blepharoplasty fat excision and then fat grafting, you're not really disturbing the midface. You're staying inside the orbit for the fat excision, and then you're using the cannula. So it really shouldn't be any different as far as lymphedema than filler, I think.
Dr. Deepak, one last question I had for you. Have you in your experience come to like an average amount of volume that you're injecting per area? What's your sweet spot?
Yeah, I mean, obviously it depends on the person, but really for younger premenopausal women, 2 cc's on each side. For older patients, somewhere between 3 to, sometimes 4, but 3 to 3.5. And then, somewhere between 1 and 2 in the superior sulcus on each side.
Okay, I lied. I had one more question. So, how much fat loss do you observe over like the first month post-op and compared to maybe 6 months post-op? Are you seeing fat attrition and atrophy?
There's a really great paper in ASJ where a group from Mayo, I think, did Vectra, 3D volumetric analysis over 18 months, and it shows that the nadir of the fat is really at 12 months. So if you look at 1 month or 3 months, you're not going to see the final result. So the fat reduces and then it comes back up and it levels out at about 70 to 80% of the initially injected volume at 18 months, and then that volume seems to persist. This is in contrast to in the 90s when Sid Coleman was first doing it, where it was 30 to 40% survival because we know how to treat the fat better. So
how do you counsel your patients with that? Do you kind of prepare them for maybe some fat loss, or are they, can you just kind of go through your discussion with a potential candidate?
Yeah, I think I haven't had any pushback from patients in saying that we're going to do surgery on another part of your body while we're doing your lower eyelid surgery. I know that, sometimes surgeons have difficulty bringing that up, but I think I tell them I need to have both tools, addition and subtraction, in my toolbox in order to give you the best result. And I think if you simplify it, people understand. So beyond that, if you counsel them, which I think all of you do, that aging is not something that stops after you have plastic surgery. People continue to age and you might need maintenance treatments in years, but in general, the fat transfer result will last, 5 to 10 years, the length of your lower blepharoplasty procedure. People are accepting of that.
Thank you.
I was going to say, I can keep going if I need to continue on. Just let me know when our time is up.
We should now invite Dr. Natalie Homer to give her talk on endoscopic brow lift. Natalie?
Thank you so much. And I echo Deepak in thanking you all for the invitation to speak today on a surgery that I love, endoscopic brow lifting. So when we look at the transition from the youthful to the aged face, we see a pattern of underlying structural changes that lead to the bothersome aging features that patients are looking to rejuvenate. And when specifically focusing on the upper face, we see gravitational descent of cutaneous tissues, lots of volume, and this heaviness that's induced in the periorbital area that can lead to both aesthetic and functional consequences. The endoscopic brow lift is a very powerful tool to rejuvenate the upper third of the face in these patients. Ideal candidates, I feel, for this procedure include those with both central and lateral brow descent, as those with only lateral brow descent. Some of our younger patients may benefit from a more limited, just temporal brow lift. Those with a low to normal hairline, as this procedure inevitably raises the forehead and the hairline, and so may be a benefit in those patients. Poor candidates, but not necessarily completely contraindicated, but may have less robust results, are those with a high hairline who might not want to experience further elevation of the forehead. Those with a receding or thin hairline, as we may not be able to camouflage our scars as well in these patients. And those with significant brow ptosis or heaviness or thick skin, cranial nerve 7 dysfunction, I find that these patients don't get as robust of results with this technique and may benefit from a more robust subtractive forehead technique, lifting techniques such as a pretracheal brow lift. We also took a look when I was in training with Dr. Chanup Nakra, who's also part of our speaker panel today, and we looked at the nasal dorsum in our patients that underwent the brow lifting technique that I'm going to show in a second here, and we found that there was this significant aesthetic and quantitative benefit in a lengthening of the nasal dorsum in our patients that underwent this technique. It just makes sense that with that gravitational descent, there can be bunching of skin up on the top of the nasal dorsum, and with a thorough release down to the nasal radix, which I'll show soon, patients can get benefits in this area too. So those with bunching in the nasal region may also be good candidates for this procedure. Essential instrumentation is, of course, good tools for visualization, which can include a 30-degree nasal endoscope that can be transformed for this procedure by adding on a sheath that fits right over the scope that allows for simultaneous retraction of the tissue and visualization. We need some good elevation tools. I like to use as my primary workhorse for my blunt release of soft tissues, the OB Geezer periosteal elevator, which is pictured on top. But having a variety of different shapes and contours of elevators can be very useful. We need good releasing tools for additional blunt release, like long Metzenbaum scissors or this instrument that works very nicely, the one at the top here called the Trepset that has a little bit of a wider base. And then depending on your fixation technique, which we'll get to, you may need a drill. But the key to obtaining a maximal and effective forehead lift is obtaining first, an adequate release, which involves the frontal area. It involves a release of the periosteum along the entirety of the orbital rim, including laterally and inferiorly. And then, of course, obtaining a nice release in the temporal fossa. Looking at incision design, the way I was trained to do this procedure that I find works very well is to make 2 parasagittal incisions that are in vertical line with the supraorbital notch. We make these incisions in a broken line pattern so that it can help to camouflage the scar. And then we make elliptical incisions in the temporal area that's centered over the superior border of the temporal fossa. Some textbooks show putting this temporal ellipse a little bit more laterally or further down on the scalp, but really the purpose of this incision is we make it in an elliptical fashion so that the subtractive nature of that incision can help facilitate additional lifting of the soft tissues in that area. And we want to do that, perform that lift in a vertical manner. And so putting those incisions more horizontally located isn't as helpful to achieving that. It's very important that we have a good understanding of the anatomy in the areas in which we'll be performing our releases, specifically in the temporal fossa. We have our frontal and zygomatic branches of our facial nerve that we're looking to avoid injury to. And so our dissection plane in this area is along the deep temporal fascia, underneath that intermediate or iatricals fat pad, which we'll demonstrate. And then centrally, we want to carefully perform a release around the important sensory nerves in that area, the supraorbital, supratrochlear nerves, which we'll perform under direct visualization. And so this is a video actually of Dr. Chanush Nakra performing the procedure technique that he taught me and that I utilize in my practice. You can see he's making that broken line or zigzag parasagittal incision, and that's all the way down to bone because we're going to be initiating our subperiosteal dissection through those incisions. This can be performed bluntly without direct visualization for the upper portion of the forehead. When we're moving surgical sites, always good to pack with a 4x4 or Raytec for some passive hemostasis. You're going to see him then moving on to the temporal elliptical incision, which again is in that more vertical vector, back within the hairline. This incision is down just beyond the subcutaneous fat, and then this ellipse is going to be excised, exposing the superficial temporal fascia below. That's the layer that the superficial branch of our temporal artery is located in, and sometimes we need to apply cautery to that artery if exposed. And then primarily using blunt dissection, we can get down to the deep temporal fascia, which is that tissue plane in which we want to be performing our dissection within the temporal fascia. We are going to connect bluntly this dissection plane to that subperiosteal dissection plane along the frontal bone, and then use direct visualization once traveling down within the temporal fossa. And so you'll see switch to an endoscopic view here. What we're wanting to do is travel along that white kind of coarse tissue plane that sits on top of the temporalis muscle. We're wanting to identify that intermediate fat pad, which we'll see shortly. And then we're wanting to connect this tissue plane to, again, that subperiosteal dissection plane along the frontal bone and release that condensation of tissue that separates those two facial compartments, the conjoint tendon, and that can be bluntly released from a lateral to medial fashion. And then you can see here additional blunt release along the bone. And localization of that intermediate fat pad, you can see that fatty tissue. We want to stay under that fat pad to ensure we're staying down deep on that deep temporal fascial plane so that we're well below where we would find those branches of the facial nerve. So just again to show, if we stay under that fat pad that's shown on that bottom right photo, where that teal dotted line is located, we have a nice cushion between where we're bluntly dissecting and the overlying tissue layer that contains those important neural and vascular structures. That fat pad is not always, extremely visible in some patients. Some patients have a little bit of a wimpy fat pad like you're seeing here, but you should be able to visualize it under endoscopic guidance and be able to elevate and travel below that fat pad. This patient here has a little bit more of a robust fat pad that can be elevated in the same way. Once all of that dissection is completed and we've reached the superior orbital rim, we release all the periosteum from the superior orbital rim. We travel down, release the periosteum off the lateral orbital rim. Some portions of that dissection can be performed without direct visualization, but fortunately we have a nice video showing that release here. And then we complete a release all the way down along the infraorbital rim as well until the infraorbital notch, the area of the infraorbital notch, because we don't want to injure that nerve, but completing a nice release along the infraorbital nerve allows for really robust mobilization of the tissues. We sometimes use our Metzenbaum scissors or the Trepsat that I showed earlier to additionally bluntly spread and get additional elevation of the periosteum off the rim. And then you can see here in this video, once that's all been completed, we sometimes do this finger test where we make sure there's no tethers remaining, and you should be able to get really nice visualization of the lateral brow tissues after that release has been completed. Centrally, we get our endoscope back out and we look at and directly visualize our dissection, especially in the area of the supraorbital notch, because the supraorbital nerve is located in that area. You can see that there. And we want to clear off the periosteal tissue around the nerve without injuring it. You can perform either a blunt or a sharp glabellar release. Here, some of the corrugator muscle fibers are just being bluntly spread against to just allow for a little bit of roughing up of the muscle so that you get a little bit of a decrease in contraction of that muscle to help with rhytids in that area. This was a nice study. Additionally, those corrugator muscles can be directly transected, and sometimes we'll do that as well. This was a nice study out of New York that showed a decrease that was lasting 12 months out from surgery in dynamic rhytid scores in the glabellar area with direct transection of some of the corrugator muscle fibers. And they didn't find that there was any increase in complication rates in the complications that we worry about with this additional portion of the technique, which could include a higher hemorrhage rate after surgery or splaying of the brows. But those are things that we sometimes worry about with performing this additional part of the procedure. And so I don't typically do a direct myectomy of the corrugators in all patients. Temporally, we can fixate to the deep temporal fascia. It's a nice stable tissue layer that we can suture to. Here we're using a 3/0 vicryl suture on an SH needle. This suture can be passed through the deep temporal fascia and then through the temporal brow tissues in order to elevate that portion of the lateral forehead. This can be performed, we usually do pass in a horizontal mattress fashion to get additional security to the suture. And then you can have a trusted assistant help to elevate the tissues with a 2-pronged skin hook while you're tying down the needle. Centrally, there's many different ways to fixate. All of these I've used in some point in my training or in practice, and I think that they all have merit in certain circumstances. Endotines, dissolvable implants can be used. A dissolvable screw can be used, and a suture incorporated within the screw in order to elevate the tissues. My preferred technique is to perform a bone tunnel, which is what's shown on the right. And here's a video of that technique being performed. They do make guides that can help to facilitate the placement of these drill holes, but typically a drill hole is able to be made through the frontal table of the scalp in opposing directions so that there is a tunnel created, and then a suture is able to be passed through that tunnel And then the suture can be used to grasp the central forehead soft tissues in order to provide lasting elevation. The suture, a variety of sutures can be used for this. I think here it's a 3.0 PDS on a similar SH type needle that's able to be passed well through that bone tunnel and then passed through the skin and tied, and provides nice lasting elevation. And by the time the suture dissolves, the periosteum should be stuck down in its nice elevated position. So with this technique, and I don't usually put any dressings, we close the incisions sometimes with some monocrystal sutures deep and then staple superficially. I don't usually use any dressings or drains with this procedure. And with this technique, when the right patient is chosen, they can achieve really nice conservative but natural looking brow and forehead elevation that can address some of those aging features that we started off talking about. So I want to thank you all for your attention. Happy to answer any questions and looking forward to participating in the rest of the discussions. Thanks.
Yeah, that was a wonderful talk. Do we have Deepak here? Deepak, would you like?
Very nice talk, Natalie. I really enjoyed it. Brows are one of my favorite topics as well. So thank you for talking about them. One philosophical question to start you off with. So analogous, to lower facelifting, where you release all the ligaments to mobilize the face as much as you can. Do you also try to release all the forehead ligaments in every patient, or do you have a differential release that you do for a shape that you're going for or for asymmetry? How do you choose where to do the release?
Yeah, I think it's a great question. Typically, when I'm trying to address asymmetries or balance out the two sides, I don't find that it alters my release necessarily. I think that the first portion of the procedure is all the same for me, and I release equally on the two sides, but I vary how much I tighten the tissue at the end when I'm fixating, or how far down I'm passing the suture, or how much I'm elevating the tissues. I don't vary my release as much, although I will say, in patients that are high risk for bleeding postoperatively because of comorbidities or things, sometimes I'll perform less aggressive, release and brow lifting procedures generally, but to address asymmetry specifically, I usually make those adjustments during my fixation.
Okay. So follow up to that, then if you know that someone is going to need a differential, tightening at the end of your case because of asymmetry, do you choose a different fixation technique in that instance?
It's a good question. I stick with the bone tunnel for most patients. I find that in my hands, it's quick. It avoids the need for us needing to obtain the implants. I have had some patients that I saw while in training and using the endotines more regularly that had some kind of fibrotic type of reactions or inflammatory reactions in the area of the endotines. And so I just find that with the bone tunnel, I can avoid some of those potential complications. So I typically stick with the bone tunnel. I actually really enjoyed previously using those absorbable screws, the Lactasorbs, but then they were no longer being made, and the alternative I haven't been as excited about, but I actually think that was sort of a nice in-between because it's such a smaller platform, but it's a little bit of a less aggressive drilling that's needing to be done in order to seat the absorbable screw than doing the bone tunnels. But in my hands, just because I'm used to doing the bone tunnel technique, I find that works well in most patients and can avoid some of the complications that can come with the absorbable implants.
Well, good news for you. I too was really sad when Lactasorb stopped being made. So I'm making a similar system that should be available in May. So but I'm with you. I'm with bone tunnels until that comes out. Another question for you. A lot of people have tried to get away from using the endoscope in brow lifting, so they call them endo style. I still stick with the endoscope because I like it for various reasons. I think you do too. How do you feel about giving up the endoscope?
Well, when I was in training, we operated kind of all over the place, and we would sometimes be in circumstances where we just didn't have an endoscope available on the day. And so I have had some experience in performing the surgery without the direct visualization. when I'm just doing a lateral or temporal brow lift, I actually don't get an endoscope out for that. I just use a lighted retractor. They're actually breast retractors, but can be nicely converted for this purpose. And I feel like you can get enough of a visualization within the temporal fossa just using that. Centrally is where I find that it's a little bit more challenging to visualize all the way medially to the supraorbital nerve. And so that's the part of the procedure I feel that the endoscope is really most beneficial for. So I think I would just be maybe a little bit less aggressive in my release centrally, and if I didn't have direct visualization of those neural structures. But the majority of the procedure, especially temporally, you can perform without an endoscope, and there's some advantages to that in terms of case turnover time and all of those things. But generally, if I'm doing the full lateral and central release, I'll get the endoscope out.
Very nice. How are we doing on time, Milind?
One question.
Yeah.
Yeah, Natalie, for the temporal incision, instead of a radial one, you're taking an ellipse, right? You're cutting out the tissue. So how is that in relation to a radial incision, and does the cutout actually help you to lift more because you've shortened the tissues?
I think that it does. I think that in patients that I'm sort of on the fence about whether they're a great candidate for the endoscopic brow lift just because they have really heavy tissue out laterally. I do think that I sometimes err on the side of making my ellipse a little bit more robust, a little larger, because I do think that the subtractive nature in that area is helpful for getting some additional lift. And sometimes when I've taken patients back because they think that they're still a little bit low laterally, just in the procedure room, I'll just actually remove a little bit more soft tissue in that area and they can get a little bit more lift that way. But I do think that the subtractive nature of the ellipse is helpful. I have done the procedure sometimes where I won't, make a full ellipse there, but on my typical patient, I will remove at least some degree of skin. And I think closure of that incision does help to facilitate additional lift.
I switched from radial to ellipse 2 years ago, and then this week I switched back to radial because I felt like I had a couple patients who had some widened scars that I didn't like. So, we go round and round, I think.
Yeah, both great options.
I'll tell you, go ahead. I was originally trained on endoscopic brows, but I have since then abandoned it and moved towards trichophytic blepharoplasty, which works better in my hands. And then because the setup is a little bit shorter, the surgical times is shorter, I'm getting pretty good results. Has anyone else I guess my biggest issue with endoscopic brow, and I guess my looking for your, opinion on it, is that it's more of a suspension surgery than a subtractive surgery with vertical lifting versus trichophytic blepharoplasty, which does take, from central to lateral, depending on if you want to go temporal crest to temporal crest or ear to ear. Could you comment on that? And then secondly, do you notice a very visible difference in the hairline being raised after endoscopic brow surgery, and how long do your endoscopic brow surgery seem to last, I suppose?
Sure. Yeah. So starting off, I completely agree. I think that in some patients, especially those patients that I mentioned that just have really heavy skin, really heavy brows, my patients with cranial nerve 7 palsy where they have very little muscle tone, I find that the suspensive nature of the endoscopic brow lift isn't enough to really elevate and then maintain an elevation of the forehead and brows in those patients. Also patients, with really high foreheads or a very, kind of curved forehead where I'm kind of lifting up against the curve, I find that I'm not going to get a good sustained release in those patients. So I completely agree that other, more aggressive subtractive techniques are more useful in those patients. In terms of the longevity of the procedure, I think when the correct patient is chosen, I think that the periosteal tissues do stick down in that higher position. I don't find that once the suture that I'm using has dissolved that there's massive descent. I think that, things really do stick down in that new position, but I always counsel my patients they're going to continue to age from there on out. And so they will get continued gravitational descent just as everyone else does. But I do think that there is some lasting elevation of the forehead after this technique, as long as the proper patient is selected. And in terms of how much, the forehead's elevated, I think it depends on how aggressive and, robust of an elevation you're performing. But I think most patients welcome a lengthening of their forehead, and the patients that we select for this procedure, most of them have a low forehead or an average forehead, and they don't seem to be bothered by it. But a patient comes in always having been bothered by their forehead already, being a little higher than they'd like for it to be, I would steer clear of this procedure. But I've never had a patient complain that they think that their forehead was lengthened, to any excessive amount. Thanks for the questions.
Milind, may I make a comment?
Dr. Rachna is trying to speak, but she's muted. So please unmute yourself, Dr. Rachna.
Actually, it was me. I was trying to make a comment.
Yeah, I've managed to unmute. So sorry, Natalie, that was a really lovely presentation, and thank you for the great videos that you shared of Tanuja's as well. I read a literature review by Mohsen Bahmani Kashkuli that I'm sure you've all heard of, and he looked at the various procedures for brow lifting, including endoscopic brow lifts, direct brow lifts, neuromodulators in the long term. And his findings were that actually neuromodulators can lift by 3 millimeters in the long term, and that endoscopic brow lifts can lift by 5 millimeters in the long term. So in terms of downtime and longevity of procedures, are you finding that your patients are going down the route of neuromodulators for brow lifting rather than the big operation, the endoscopic brow lifts? Is it still an operation that you can sell?
I find that it is. I typically follow my patients, not for a total extended period out from surgery, although of course patients can come back if they ever notice that they're having recurrence of brow ptosis. But I usually see them at about 3 months out, and they're still, looking to have, gained the benefit from the procedure. I do use some Botox and, other neurotoxins for elevation of the lateral brow. I don't find that it gives me a lot of elevation of the forehead otherwise. But I think it's a really great option for some patients that have just minimal descent. But yeah, I know it's debated. It is mostly a suspension procedure, as mentioned before. We do a little bit of subtractive to the skin in the temporal area, but I really do think there's something to be said for things being elevated and sticking down in that new position. I think there is some longevity to that. Maybe in different people's hands, different techniques might work better.
Yeah, we'll take one comment from Sabrina.
Do we have time?
Yeah. Milind, I just want to make a comment because it's quite interesting. I think in UK, we see a paradigm shift even from our craniofacial and plastic surgeons, where they are moving towards more gliding brow lift and more subtractive techniques. And they find that they just, so traditionally now for almost a decade, we've had people bob around. They've gone to endo, they've moved back to trichophytic or pretracheal, they've developed gliding brow. The direct brow lift, interestingly, has made a comeback. And I think that, Natalie, your talk was absolutely excellent, as was Deepak's. But I think that it's the consistency of result and being able to match the particular procedure to that particular patient. And I feel that we're not there yet. That's why we're bobbing around between all these procedures, that, which patients are ideally suited for an endoscopic brow lift, because right now it's like a melting pot. And I think it is skill-based and technique-based. But in UK, we've really seen, an paradigm shift away from endoscopic brow lifts, where they're just incorporating more subtractive techniques. So I'm not sure if Alice and Kyungwon have seen a similar shift, and if Milind has seen a similar shift, because USA and Brazil seem to be doing more endoscopic brows if you look at countrywide data, from across the globe. So I'd love your comments, please.
Well, I guess we'll come back to this, but we should go ahead with the talks for now so that we don't lose out on these speakers. Tanuj, is it okay if we take Rachna's talk? I know yours was aligned for now.
Go for it. Yep.
Okay, so we'll invite Dr. Rachna Murthy to talk about the dark side of cosmetics and the periocular area. Very interesting talk and a lovely write-up that she has as a publication, which she shared with me, and I intend to read that this week.
Can you all see my screen there? I'm just going to start the screen share. Milind and Kasturi, thank you so much for inviting me to come and present on this literature review. It's a huge literature review. Actually, this is the elephant in the room, because we're sitting here talking about cutting edge aesthetics and all the procedures that we can do to improve the periocular area for our patients. But actually, it's what our patients do when they go out of our clinic room and our OR and the kind of things that they're putting around their faces and their eyes that are causing aging. And so we're fighting a losing battle in many ways. And so what I'm going to in the next 10 minutes, just talk you through this. And as Milind said, this is a massive literature review, which was published last year in the Tear, Film and Ocular Surface journal that I was invited to co-author. And this was the most read article in the Tear, Film and Ocular Surface journal last year. So I do urge you to read it when you have several months spare to be able to go through the multiple pages. But I'm going to try and summarize some of what we found. So here's a little picture, and I want you to just imagine a door-to-door salesman going from city to city, place to place, and he has a lotion in his hand which promises to reverse all the signs of aging and make your eyes bright and alluring. And you have a look at that bottle and you turn it around, you put it in your hand, you have a look at the list of ingredients, and it's in a foreign language. But this magic snake oil promises to give you 10 years off your face. You're interested, right? We're all interested. We want to buy some. We want to buy it for our family. So are we still buying snake oil? This is the 1800s that I'm talking about in the Wild West. No, this is actually a really good depiction of what's going on with modern day cosmetic marketing coming to our houses every single day through social media, through the TV, through consumer press. And it's not just reaching us, it's reaching our children as well. And so are we still buying snake oil? And are we aware of what we're putting on our faces? So this is not a small problem. The cosmetic market is a huge industry, and it's rapidly growing. It's a multi-billion-dollar industry globally. And these are just figures from the US. But 90% of women under 55 wear cosmetics in the UK, and at least 12 different products. And actually men wear 7 different grooming products on average. So it's very socially acceptable for men to use some form of grooming product, whether or not it's a cosmetic. And the most common things that are used around the periocular area, things like mascara, eyeliner, and eyeshadow. But it's not just adults that are using it. It's not just the domain of us adults, it's our children as well. So 54% of girls aged between 12 to 14 wear eye makeup in the US. And this is mirrored in the UK, and I'm sure it's mirrored globally. So we have always been preoccupied with the periocular area. This is not something new. So gaze tracking studies from the 1970s by Alfred Yarbas, who's a Russian scientist, looked at where our eyes focus when we communicate with other people. And you'll see that the tracking studies show that we flip from eye to eye and then to the nose, then we land back on the eyes. So we are all concerned about keeping the eye area looking aesthetically pleasing. And we're not just a self-selected group of people who are interested in ocular plastics. It's what our consumers want as well. And so before antiquity, eye makeup was used to speak with the eyes, and black coal and kajal, which we still use, contained things like galena, which is lead sulfide, and some very toxic things. This last picture on the right-hand side is a dilated pupil for the observant, if you can see it on the right-hand side, used by the ancient Romans to make them look more beautiful. So atropa belladonna meaning beautiful lady, and actually this is a toxin. So naturally occurring things and organic things are not necessarily safe. They can contain toxins. And so if we fast forward to the early 20th century, there was commercialization of these cosmetics and products, and you'll recognize some of these brand names which have been around for a long, long time. And we've added to our armamentarium of periocular rejuvenation with things like fillers and toxins and lash extensions, lash serums, lasers, and the surgery that we do. But unlike lasers and surgery and fillers and Botox, which are fairly well regulated in most countries, cosmetics are not regulated at all. And actually, you know, there are 12,500 chemicals in cosmetics that the US FDA estimate, and only 11 of these have been banned in the US since 1938. You know, 11 out of 12,500. And slightly more regulation in the EU, only 1,300 banned still. So that's less than 20% of ingredients have been reviewed for general safety. So if we take that number, that if you took less than 20% of safety checks in an aeroplane, would you get on that aeroplane and fly in it? Probably not. But we are putting things on our faces every single day. And those have been checked in less than 1/5 of the ingredients that are in there. The problem is that very little literature out there. There's paucity of data and clinical trials, and eye safety is even less reviewed. So this is a group of 12 of us who were invited to be part of this global international panel 3 years ago. And it's taken 3 years from inception to publication to get this huge narrative literature review, which, as I said, is a book. So you'll be glad that I'm summarizing some of it for you here, but do go and look at it. It's level 1 evidence, so there is positive evidence, but you know we took all the literature reviews out there regarding all the different cosmetic ingredients that can affect the periocular area and the eye surface, and we also looked at cosmetic procedures and energy devices. Cosmetic ingredients can cause a number of different problems. They can cause allergies, irritation, dermatitis, blepharitis, meibomian gland dropout, dry eyes. They can cause lipoatrophy around the periocular area. But worse still, they can cause endocrine disruption. And you know that's particularly relevant for our children who are using these products. There are estrogenic and androgenic components to these products. Some of them are neurotoxic and some of them are carcinogens, and we don't know about it yet. And when we look at the bottles and we look at the ingredients to see what's in it, even if we're trying to protect ourselves and our families, it often reads like a foreign language. So how do we know what's in it? So we looked at the top 10, and this is listed here. I'm going to go through a few of them. Benzalkonium chloride, formaldehyde-releasing compounds are throughout all of our cosmetics, retinols, and tea tree oils, which we regularly will prescribe to our patients for their blepharitis, can actually be very harmful to the ocular surface and cause worsening of the dry eyes. So if we take back, you've all heard of benzalkonium chloride. It's a preservative, and it's used very commonly in glaucoma drops and lots of other eye drops that we prescribe for our patients. It's in cosmetic products like eyeliner, makeup, mascara, and it's toxic to the cornea and the meibomian glands. Concentrations that are maximally allowed in cosmetics of 0.1% are 200,000-fold higher than what can be toxic to the eye surface. So it doesn't take much. And this is a cumulative use. These products are used every single day. So it's not just a one-off event like an operation or an energy device. Formaldehyde-releasing compounds. Well, we know about lash glues and lash extensions, which can be quite nasty to the eye area, but this also present in lots of mascaras, shampoos that we use to clean our hair. And again, these can be toxic to the eye, but they're also mutagenic and they can cause cancer. And the concentrations required to be toxic are 2,000-fold lower than what's permissible in these cosmetic ingredients. Parabens are also genotoxic, carcinogenic. Prostaglandin analogs, you will all know about now. Blepharoplasty came in over a decade ago. These patients shown here were 2 of my patients that I treated unilaterally for glaucoma in 2008 with the high dose blepharoplasty that doesn't exist anymore. But they had all the signs of the now well-recognized prostaglandin analog syndrome, so deep superior sulcus, hyperpigmentation, lipoatrophy. And I presented this in 2008 in an Esoporus, and I actually recommended that it might be used for thyroid eye disease. And so people have looked into the use of Blepharoplasty for thyroid eye disease since then. It was rebranded as Latisse, which is the lash serum, and that was FDA approved prescription only for people who had lost their lashes, but it's now abound in over-the-counter lash growth serums, and so can be causing significant issues around the periocular area. So always ask your patients whether they're on some form of lash serum if they're coming with hollow eyes before you start putting fat around the eyes, and stop that lash serum use. So how can we check for these ingredients? There are some websites available. You can take a picture of this. There are apps which you can actually scan the ingredient code bar, but we're not there yet in terms of safety. What can we do to make our patients more aware? There are things like retinols. Virtually everybody is on a retinol in the UK at the moment, and we're using them close to the eyes, and they can cause dry eyes and damage the meibomian glands. Technique is also important. Many children, many of us are applying cosmetics right up to the lash line and to the waterline. So this can block up the meibomian glands. It can migrate to the ocular surface. So discuss how mascara and makeup is used. And maybe consider switching out from the waterproof products to the non-waterproof products, because the waterproof ones require more astringent alcohol-based removers. Speak to your patients about the cosmetics. It's a holistic approach that we should be having with our patients, not just a one solution. So I'm going to stop now because I know that we're going to be limited for time, and thank you very much. I need to acknowledge my business partner. I'm now in full-time private practice, and I left the NHS 4 years ago and working with Professor Jonathan Roos in London. So thank you for listening.
Thank you, Rachna. And Shubhra, over to you.
Hi, Rachna. A wonderful talk. A lot of insight into what goes on into the product, especially in the periocular area. And it definitely is an eye-opener, because I think the market has just been carried away and swayed away with these products and, the kind of over-the-shelf products which are available. And I think this talk also emphasizes on the use of protocol-based and medicated products to be sold and treated by the physicians, which I think is the need of an hour. So I think that's a wonderful talk. And what question can I ask you? I mean, have you seen with all these chemicals being there in the market, I mean, what's the one of the most common sequelae or the side effect which you have seen in your practice, which was just like you couldn't believe that happened and you've seen it for first time? Because whatever you've narrated is pretty common and we see it very often. So have you seen something out of the world case which was possible, which happened because of the wrong use of the products around?
I think that, we always notice the awful cases, the lash extensions, somebody sticking their eyes together by mistaking the chloramphenicol ointment or the fusidin ointment for their nail glue or something else like that. But I think the silent, deadly problem is the cosmetics that people aren't presenting with, and it's happening slowly. It's the patients coming in with irritable eyes. They're coming for their cosmetic improvement with the surgery that you're going to offer them, or the fillers or the neuromodulators. But if you don't ask the question about what they're actually putting on their eyelids or around their faces, men and women, then actually, that what you're doing for them, they're going to go back and make it worse. I always say to my patients, I'm going to be doing some treatments for you if they're in the clinic, the cosmetic treatments. But I'm like a dentist, and if I go to see my dentist, I go home and brush my teeth every day. So I encourage you to have some form of skincare, but safe skincare. And so it's really important that you expand your practice to incorporate skincare. People are going to be more interested in safe beauty, and they're moving away from clean beauty, and it is all about safety now. So I think it's a discussion to be had, even when you don't see any nasty sort of horror things sitting in front of you at the slit lamp. You have to open up this discussion.
I endorse it and completely agree, because I think as oculoplasty surgeons, and Tanuj, you can add on this, is that I think as an oculofacial plastic surgeon, especially here in Asia and in India, we kind of not pay more attention to the skincare and the augmented practices which are there in addition to the surgical practices. And I always tell the patient, skin is the first window to any surgery which we are going to perform. And it's very important for people to understand that, as I mentioned, protocol and medicated base, safe skincare, eyelash products, or whatever we are talking about, I think that education and awareness is must. And as you said, taking the history on that. I leave the discussion to the other panelists if there anything to be added on this note. Thank you. Wonderful talk.
Shubhra, you asked
something to
about
add.
something. Sorry.
Go ahead, Sabrina.
Tanuj, sorry. I've seen 4 patients with severe ptosis, which they didn't have, and they've been wearing the most awful false eyelashes. And I think for me, in all these years, England had this trend of false eyelashes that were that long, and these women were sticking in and coming in as if they were, they had wings on their eyelids. And they actually had photographs of what they looked like, a year before they had started wearing these eyelashes, and they developed ptosis, and they didn't have any other reason to be. So I've seen ptosis from just the weight of the eyelashes. So I think that this trend, forget the dry eye issues that are known to occur with the length of eyelashes, is an optimal length and density of eyelashes. So I think the false eyelash trend, particularly the lash glue, the length of the lash, dry eye, and the impact on eyelid ptosis is something that needs to be explored.
Yeah, in many ways, I mean, that's going to expand our practice, because, of course, they're all going to come to us to have their ptosis and their blepharoplasties done, because they'll use
we must thank them. We must thank them to get those additional cases. Yeah, Tanuj.
2 quick comments. Very, very nice talk, Rachna. Firstly, I think that you bring up a good point, and Shubhra actually commented on this, which is that, as oculofacial plastic surgeons who are communicating with our patients every day, everybody who is practicing in the field needs to be fully educated on the power and the science behind skincare, because we have to provide our patients real information to be able to combat whatever they're learning out in the media, which is mostly inaccurate. Marketing claims are wild and usually invalid by most skincare companies. So it's our responsibility to be fully educated so that we can actually give our patients real information. And then one specific question for you, Rachna, is totally appreciate your comments about side effects from prostaglandins. Has there been a study comparing actual intraocular absorption of topically applied to the eyelid prostaglandins versus the actual drop that hits the surface of the eye? There's probably a big difference in absorption into the periocular circulation. Curious about that from your standpoint, because in my experience, there's a big difference in side effect between, topical prostaglandin on the lash versus, ocular glaucoma drops.
Yeah, that's a great question. And, it stemmed from this presentation I made a long, long time ago that it spawned, and I see that Anya Eckstein is on the picture here, that this was being studied by patients, by doctors who are interested in thyroid eye disease, and to see whether they could improve the adipogenic phenotype of the thyroid eye disease with using a topical treatment or an injectable treatment of this prostaglandin analog, or using drops. And so there was a huge study which was performed in Cardiff, and they looked at the different results in terms of using drops and on topical treatment. They didn't look at the concentrations in the eye, but they took pictures, serial pictures, to see whether or not there was going to be fat atrophy. And unfortunately, they didn't find any significant improvement in the excess fat in their thyroid patients. And I think it was because it was not targeted at the concentrations that's required, and they didn't have long-term follow-up. So it was over a year. So I don't think that there are any other studies since then that have looked at the concentrations. I believe that this is still an option for people who have a loss of excess fat in the eyelid. And I do put all my thyroid patients on this drop if they have glaucoma, because I do think it will be beneficial, and they'll be on some topical glaucoma drop for a long term.
Yeah, and at least for the eyelash patients, you know, who are using it for cosmetic lash growth, we'll have them reduce the frequency from what the manufacturer suggests. It doesn't need to be applied daily. You know, once they get to a desired length, they can drop it to every few days, and that usually maintains the growth that they want.
Yeah, and it's good because they continue to see you, so you're monitoring it. It's the people who are out there in the community, and the children that are using it from early age, that we can't monitor or regulate. Brilliant.
Hi,
Thank you.
here again. In the interest of time, we'll take the next two talks in succession, and then we'll have questions. Tanuj, over to you.
All right. Well, I have been given the honor of speaking about blepharoplasty, which is, of course, the bread and butter of our specialty. I'm going to cover as much ground as I can in 10 minutes here on the state of blepharoplasty in 2024. I'm reporting from Austin, which is in the southern United States. We are a growing city. We have a brand new medical school at the University of Texas at Austin, which we are affiliated with. We have a growing team, and we'd love to connect with all of our colleagues around the world and invite people to come visit us if you wish. So I'd like to discuss 10 ideas here, and I'll try to be informative but also efficient with my time. And we'll start with discussing some concepts on upper blepharoplasty and then also some lower blepharoplasty ideas. And this is a compendium of kind of newer ideas and concepts that I'm incorporating into my technique these days. Now, the first cephalic orbicularis trim is really not a new idea. I have to thank Naresh Joshi for giving a presentation on this topic 15 years ago. And during standard blepharoplasty, I routinely will resect some portion of orbicularis muscle, which goes against the grain of anybody who's trained with Bob Goldberg. But I find it to be very useful to resect lateral orbicularis away from pretarsal orbicularis. And this maneuver of cephalic resection with preservation of orbicularis inferiorly reliably offers a brow lifting approach that simulates what Botox can do, because after all, Botox weakens this lateral orbicularis. And so this is a very useful technique for patients who've never had surgery before, who don't have severe dry eyes, and who are looking to achieve as much finesse and elevation as we can from a blepharoplasty. Recently, I have been using the technique of repositioning in the upper eyelid frequently. And we all know that the volume status of the eyebrow and the eyelid are married together, intermingled concepts. And as we lose volume in the subbrow fat pad and in the orbit, it changes the configuration over time. And so we have developed techniques to release the brow from an upper blepharoplasty approach and utilize the central fat pedicle as a volumizer, augmenting the lateral brow fat pad. Here's another view of the central fat pedicle, and we've released the lateral brow attachments all the way to the supraorbital nerve and transposing this pedicle up under this space, which simultaneously prevents the ligaments from sticking back down to their lower position and also volumizes the lateral orbit. And this has become a reliable option for patients who are having isolated blepharoplasty with mild brow descent and brow volume loss for cosmetic augmentation of the lateral brow and some mild lift at the same time as an upper blepharoplasty. And this was recently published in the Green Journal, and there's more details there if you'd like to see that. Now, in addition to transposing central fat to the subbrow space, I think there's a lot of utility in analyzing the relationship between the medial fat pad and the central fat pad in the upper eyelid. And if we look at this patient here, we can see that she's hollow laterally and relatively full medially. So this is an ideal patient for us to mobilize the medial fat pad during blepharoplasty and lateralize it and attach it to the central fat pad with individual gut sutures to commingle this fat into a single pedicle that transposes the volume laterally. Here's the patient after a conservative brow lift, upper blepharoplasty, and notably the fat transposition from medial to lateral. Let's talk about subbrow blepharoplasty. This is a typical kind of scenario where we have a patient with a low brow position and for whatever reason is not going to have a brow lift. Well, we can, in fact, work on the brow from a blepharoplasty approach by transposing the typical incision on the crease centrally to more of a subbrow location where we're operating on the thicker brow skin, which also allows us to resect subcutaneous fat in the subbrow region. And so here this was presented by Angela Service in Australia using this technique to resect skin from directly under the brow. We can see that there are some fine scars that are left behind in the subbrow space, but on the other hand, we also see substantial improvements in the subbrow volume, and with long-term healing, these can heal well. Here's a patient at 1 month who has some typical hyperpigmentation in that subbrow area after a subbrow blepharoplasty, but with time, we found that these techniques do produce results that are pleasing for patients. Now, this is a good time to talk about our post-op scar protocol that we utilize in almost all our patients with visible incisions, including standard blepharoplasty. I'll have them all on a topical steroid cream to modulate wound healing for the first several weeks, and then we'll use silicone gel for a few months for the patients who are motivated to make sure they have the best scientific approach to healing wounds. Let's talk about sulcus and crease control in blepharoplasty. Now, we all know that incision location does not determine the location of the crease, but rather it's the attachments of the levator to the anterior lamellar skin. The highest point is really where the crease will be. And so, during blepharoplasty, of course, we can perform supratarsal fixation. This is certainly a workhorse in our specialty for controlling the crease. And this can be, a very nice technique. Of course, there's a whole world of discussions that we could have around crease fixation and design with Asian blepharoplasty, especially with medial canthal anatomy. One of the more simple things that allows for crease tightening in patients who just need a mild enhancement is creating a full thickness burn during surgery from the orbicularis down to the tarsus without even opening the septum. This can tighten the crease in patients who have an acceptable crease and just want some mild improvement. Now, some patients will need all the bells and whistles to be able to create cleavage between the brow and eyelid. Here's a patient who underwent upper blepharoplasty with a relatively assertive removal of orbital fat. This is the one scenario where I'll perform that kind of an approach. And then crease fixation with lateral orbicularis resection, as well as a little subbrow fat sculpting. So this is exposure of the subbrow fat pad, lateral orbital rim during blepharoplasty, and we can judiciously remove a portion of the subbrow fat pad to be able to create this level of cleavage for these patients who have a low brow position and a very full subbrow fat pad that's invading the upper eyelid space. Let's talk about suturing options for upper blepharoplasty. These days, we see all over social media how utilizing the subcuticular closure can be a sexy way to make the upper eyelid incision close. I certainly think there's a role for this in certain patients. It does reduce, in my opinion, some of the relative ischemia that can occur at the incision edge due to less constriction on the superficial skin from suture lines. But still, our tried and true workhorse of standard running closure is utilized in most patients to be able to truly control the wound edge, especially laterally where we switch to a baseball closure technique. This allows for less wound torque, definitely less dehiscence laterally in these patients. And the immobilization that occurs here allows for a better cosmesis for the wound healing. Let's switch to lower blepharoplasty now in this whirlwind potpourri that we're taking on upper and lower blepharoplasty concepts that are new in our practices these days. The biplanar approach to lower blepharoplasty. So when we talk about lower blepharoplasty, the fat transposition technique, certainly doesn't need any introduction here, but it is a wonderful way to release the retaining ligament of the periorbital region and mobilize orbital fat to augment the cheek. But sometimes it's just not enough to just move the fat down into the cheek. We have to consider ways that allow for elevation as well as inferior descent of fat. And so this is the biplanar approach where we mobilize orbital fat and augment the cheek, but we're simultaneously utilizing a complete cheek ligament release approach to perform a cheek lift and elevation of a skin orbicularis flap at the same time. So here's a schematic where we're releasing the facial ligaments in the periorbital region, but also down in the cheek, mobilizing orbital fat downwards, and then elevating the entire midface upwards and lateral simultaneously to create this biplanar approach. Here's a 2015 article that summarizes a lot of the salient steps in that approach. Now, in addition to transposing fat, I wanted to discuss a newer technique that we're using where we're commingling the fat as we're moving it down into the face. So in addition to a medial fat pedicle and a central fat pedicle, typically most of the time, the lateral fat pad is simply excised during transposition lower blepharoplasty. There's been attempts to try and mobilize and move the lateral fat pad as a separate pedicle, but oftentimes it can look a little lumpy and a little disconnected from the rest of the surgery. So if we keep the attachments of the central and lateral fat pad intact during lower blepharoplasty, I'm going to switch to a way to just move a little forward in the video here. So, while we're transposing this medial fat pedicle using standard transposition techniques, I'll also showcase how we can use a commingled central and lateral fat pad here in this video. So I like to use a furrow gut suture and transcutaneous percutaneous fixation, and these sutures are typically removed between 3 to 7 days after surgery, depending on skin type. This pocket is fairly robust, extending all the way from the nasal bone down past the infraorbital nerve. And here we're notably attaching the lateral aspect of the medial fat pad to the medial aspect of the central fat pad. And what that does is it really attaches the medial and central fat pads together to avoid any step off or transitional contour issues that can exist between the medial and central fat pads. And so again, we're using this mini Keith needle to secure the suture to the edges of these pedicles. And then we place this transcutaneous fixation suture through the cheek. You can see how inferior that suture is placed to direct the pedicle downwards. We don't have to pull it all the way down into that hole, but having that exposure is really critical. Now here's the lateral fixation of that commingled fat pad. We're attaching the most lateral aspect of the lateral fat pad out laterally. You can see there's an additional suture in between the central and lateral pedicle to secure the typical location of the central to lateral transition. And this allows for a smooth redraping of all the inferior orbital fat down into the cheek. Let's talk about free fat grafting during lower blepharoplasty. So in addition to subperiosteal pocket creation, we can extend the subperiosteal pocket along the piriform aperture, which allows for free fat placement into this space. This free fat can come from the upper blepharoplasty. It can come from the lateral fat pad, and we transpose the orbital fat into place to lock these fat grafts into place. And this can be a way to allow for a little extended augmentation in patients who really have a flat midface. But in addition, when there's asymmetry, like this patient who has a flatter left cheek compared to her right, we can add extra volume to the left to give her better long-term symmetry of cheek volume, which really enhances the typical transposition lower blepharoplasty, which would have not addressed the cheek to that degree. And then I will just briefly show these pedicles, these free fat grafts going down into place. So again, this is fat that was taken from the upper blepharoplasty and then utilized as a free fat graft during transposition lower blepharoplasty. And then after this fat has been placed, we perform a standard approach of transposition with percutaneous fixation. So just to kind of finish off our talk, a couple of adjuncts to discuss. We had a great talk by Natalie Homer about brow lifting. I think brow lifting with an endoscopic approach does have immense power with a complete release, which includes a full temporal release all the way down into the midface along the zygomatic arch. I think that is really the key to getting a true elevation that is lasting, so it can create a permanent change for patients. So brow lifts can be used to create true facial anatomy changes. And it also preserves the benefits of blepharoplasty by someone who has a lot of frontalis tone that's going to drop after a blepharoplasty. The brow lift will preserve the location of the brow so that it doesn't drop into the eyelid. Fat grafting, again, we had a lovely talk also. I think it's just a wonderful tool to add icing to the cake of blepharoplasty. This patient had an upper blepharoplasty, but also just simple periorbital fat grafting and a chemical peel, no lower blepharoplasty, no brow lifting here. This is what augmentation can do to enhance the results of a blepharoplasty. Laser resurfacing is also in that category of enhancements where a fractionated CO2 or erbium laser can enhance the results of a blepharoplasty. We have published our techniques of using a relatively high energy periorbital resurfacing to enhance the outcome of blepharoplasty. And we found that really just laser resurfacing alone, using the settings that we've published, can actually result in a 13% reduction of the anterior lamella. So it can be a replacement for blepharoplasty in certain cases. Here's a patient who had periorbital resurfacing and a lower transposition, and we can see how that helps the periorbital skin, not just lower eyelids, but also the upper eyelids. And then finally, I wanted to talk about something I've become quite passionate about, which is improving the techniques of pain control for our patients. I like to avoid narcotics as much as possible, even with major surgeries like facelifts, brow lifts, neck lifts. The combination of using Cymbalta, which is duloxetine as an antidepressant, it actually changes the ratio of dopamine, serotonin in the brain, so it reduces the pain sensations for patients. And we use it for 2 days, the morning of surgery and the day following surgery. And that then will allow us to use simple Tylenol, gabapentin, and celecoxib or Celebrex as the primary pain control medications for patients. We've also found that caffeine is a surprising adjunct to pain control, and we'll make sure all our patients receive their favorite source of caffeine after surgery. So I apologize for speaking quickly as we kind of rush through new ideas in upper and lower blepharoplasty that I've been utilizing. Thank you for your time, and I'd love to discuss further if time allows.
Thank you, Tanush. I'll now invite Dr. Kyung-In Woo to have her presentation. And if Sabrina can make one comment or one question while the next presentation comes up.
All the talks have been excellent. Tanush, that was an excellent overview. Too many questions and we're short on time. So perhaps in our discussion later on, I'll let Dr. Kyung-Woo start.
Over to you, Dr. Woo.
Dr. Wu, you need to unmute your mic.
Thank you for inviting me to this wonderful session. I'd like to talk about the aesthetic implications of the oriental eyelids. Oriental eyelids are characterized by the lack of eyelid crease, high volume of eyelid, and high rate of epicanthus of varying degrees. Let me talk about double eyelid surgery. Non-incisional method is easy to perform, minimally invasive, and provides rapid recovery. It is a popular procedure in the cosmetic clinics in Korea. However, fading of the creases is the most significant limitation to be applied to all patients. This is an example of non-incisional blepharoplasty. The patient underwent the surgery for asymmetric crease and showed good results. This patient also showed good cosmesis after the surgery. In the incisional method, a dynamic crease can be formed when the lower skin flap is anchored to the levator aponeurosis. On the other hand, a static crease is resulted when it is anchored to the tarsus. Dynamic crease is desirable for cosmesis. However, it is difficult to achieve since we cannot control fibrosis process after the surgery. Let me move on. Crease height. Some of young men prefer no crease, like this patient. This patient also preferred no crease for levator surgery. This man preferred to have small double eyelid crease. Usually young women prefer natural-looking eyelid crease like this patient. Subbrow blepharoplasty becomes popular in Korean patients. This technique is used for patients who want to keep their natural creases, have thick eyelids, and have relatively long eyelid length. It is not suitable to the patient with severe dermatochalasis, and it becomes popular in the young patients. This is the patient with subbrow blepharoplasty. Mild degree of dermatochalasis was corrected without manipulating the natural eyelid crease. Epicantoplasty is an essential procedure to have attractive eyelids. There are many types of epicantoplasty. I'm going to talk about root C epicantoplasty and skin redraping method. This is root C epicantoplasty. The lower directing flap is moved to medially to lengthen the vertical skin shortage. As you can see here, the epicanthal inserting point to the lower eyelid is moved medially and superiorly after root C epicantoplasty. Let's see about the surgical procedures of the root C epicantoplasty. Make a mark at the medialmost point of the medial canthus first, and draw the first line horizontally, and draw another line along with the epicanthal fold. Draw the third line to the most medial canthus. The flaps are raised and dissected. Tight fibromuscular tissue constituting the epicanthal fold is resected. Lower edge is closed first, and then trim the other flap to fit the bed size. This is wound healing process after root C epicantoplasty. A patient underwent levator resection without double eyelid crease and root C epicantoplasty. Another patient with levator resection with small double eyelid crease and root C epicantoplasty. The patient underwent levator resection with double eyelid crease and epicantoplasty. Let me show you another technique of skin redraping method. First, measure the epicanthal fold depth using pull and release technique. It was 2 mm in this patient. By measuring the epicanthal fold depth, we can avoid overcorrection. After medialmost point marking, a horizontal line is drawn to the medial canthus, and then it is extended to laterally. After skin incision, the lower flap is raised. After the dense tissue is excised, medial canthal suture is placed. Lower skin flap is redraped medially and sutured with 7/0 nylon. The closer to the eyelid margin, the less scar is formed. This patient underwent levator resection with double eyelid crease. Even in the early postoperative period, there is no visible scar at the medial canthus. This patient also underwent levator resection with double eyelid crease and redraping epicantoplasty. Let me show you a detailed surgical procedure of root C epicantoplasty and double eyelid surgery. This patient had a relatively thick eyelid and high fat volume, no definite eyelid crease, and a mild degree of the epicanthus. Let's look at the surgery step by step. Design the root C epicantoplasty. The double lid crease line is marked at 6 mm in height, leaving 14 mm of skin from the eyebrow. Flap incision is performing. Upper flap is dissected. Lower flap is dissected. Tight fibromuscular band is cut. Then two flaps are rotated spontaneously. For double eyelid surgery, skin muscle flap is excised. Pretarsal orbicularis is further resected just beneath the eyelid crease line. Medial preseptal orbicularis muscle fibers, which constitute the epicanthal fold, are grasped with forceps. The tight fibers are resected to soften the epicanthal fold. Make sure the double eyelid is formed properly. By tightening the orbital septum, we can see the preapneurotic fat seen through the septum. Open the orbital septum and extend the incision laterally. Preapneurotic fat is prolapsed. The fat pedicle is severed to debulk the fat volume. Medial pretarsal fat is excised to expose the tarsal surface for crease fixation, which is a common finding in Asian patients. Bleeding can be encountered at excision from hidden vessels. The lower skin muscle flap is sutured to the end point of the levator aponeurosis and upper skin muscle flap. 4 anchoring sutures are placed. Confirm the eyelid crease shape with proper cilia angle. This picture was taken at the end of surgery before continuous skin closure. This is a patient at pre and post-op 1 year. In summary, these are current trends in practice. Natural-looking double eyelid creases are preferred by women. Small eyelid creases are preferred by men. Subbrow blepharoplasty can be beneficial in those who want to keep their own crease with mild dermatochalasis. Recently, it becomes popular in the young age group. They may be willing to have eyebrow tattoo after the surgery to hide the possible scar. Epicantoplasty is essential for more open look. Thank you for your kind attention.
Thank you so much, Dr. Wu. Aarti, would you like to make an announcement before we discuss the last one?
So we were to close this session at 11:40, but I see that this session is going really well. I'm getting comments that the session is very informative. So we thought we'll allow you to continue for another 15 minutes. For our audience to know that we will start our next session, which is on management of uveitis in Hall B at 11:45 sharp. And this session will be continued here for another 15 minutes. And it is being recorded, so you can go back and see that again. So over to you, Dr. Milind, to continue this session, the wonderful discussion.
Thanks, Aarti. I would hand over to Alice for the discussion of the last talk, and then we'll go to Sabrina.
Okay, thank you. Thank you so much for being here. And thank you for the invitation to be one of the panelists. Great talks, Dr. Wu. Always good to listen to your lecture. And aesthetic eyelid surgery in Orientals or East Asian has always been something I'm very passionate about. And this is a surgery that I do almost every day in my practice. So a few questions for you, Dr. Wu. The Oriental eyelids has always been a very challenging structure to create a crease. So one of the questions I have is how do you always ensure the symmetry of the crease in the double eyelid surgery, considering the unique characteristic of the Oriental eyelids?
That's a very good question because I always the most common side effect or poor result from the Asian blepharoplasty would be the asymmetry of the eyelid crease. It can be from the brow position changes, but mostly it is related with the adhesion, I think. So we make a very symmetric design, but sometimes we make higher adhesion to make a bigger, higher eyelid crease. So to prevent the kind of higher crease, we need to we need to manipulate the tissue very carefully, and then usually we leave the superior part of orbicularis as intact as it is. I mean, if we manipulate more to the upper orbicularis muscle, then it will adhere to the wound and then make some a little bigger eyelid crease, I think.
Right. I personally have reduced the incisional method for the double eyelid formation because I realized that, the more cutting that you made on the lid, there are more chance for you to, it's a bit more difficult to control the amount of, incision and also the amount of suturing that you have, the depth of the suture. So these days I've actually, moved away from a full incision and going to very minimally invasive or what I call the micro incision type. So I hope maybe in the future I have an opportunity to present that. Another questions that I have that you talk about, sub-brow blepharoplasty. So, because we know that the skin around the eyebrow and, in the eyelids are different in thickness. So how do you ensure that seamless skin closure when you are trying to close between the eyebrow skin and the eyelid skin?
Yes, that's a very good question. The skin thickness is very different from the brow and then lower. Especially in the Asian eyelid, upper skin, brow skin is very thick. So I think we need to match the suture depth between the upper and lower skin to leave less scar. And then before the skin's closer, we need to approximate the orbicularis together and then match the suture height between both sides. I think that would be preventable measure.
Okay. So my approach to this would be in patients who have severe dermatochalasis, especially the lateral hooding. So sometimes I combine a little bit of a micro incision at the lid area and I do a little bit of subbrow. So it's a combination of removing a bit of skin in the subbrow area and also tucking the skin on the lid crease level. So in that way, you can actually reduce the amount of skin removal in the brow, transitioning from the brow to the eyelid skin. Yeah. Anyway, so my last question for you, this is a question I also personally find it challenging. So which method do you employ when you have to reverse an overcorrected epicantoplasty?
It's very difficult. So that's why I say about the measure the epicanthal fold and then just to prevent the overcorrection. In my technique, I haven't have any overcorrected cases, but I do have the kind of revision cases because of the referral or patient want to have surgery from me. Usually in Korea, most epicantoplasty is done under the redraping method. So the reversing the redraping is I think the most important, most efficient thing, I think. So the same incision line along with the lower eyelid margin, and then move to the tissue to medially, and then have some fold over the medial canthal fixation. I think that they can be the best choice, I think. But scar is always the problem because of the second surgery. So we need to say about that to the patient as well.
Yeah. I think for me, the first thing, like what you mentioned before, is always better to undercorrect epicantoplasty because it's a lot easier to revise another correction than to actually do a revision for overcorrection. Well, that's all from my questions, the questions that I have, and of course I open up to the rest of the panelists. Any have any questions for Dr. Wu?
Thanks, Alice. Sabrina, would you like to have some comments, discussion on the blepharoplasty?
On blepharoplasty, I mean, look, both the talks were excellent. I just have a couple of questions for Tanuj. Excellent talk on your 10 ideas. I wanted to touch base because, like Alice, I do two approaches where I would do subbrow with the skin crease. And I wanted to ask you, Tanuj, in your experience for the medial skin, because that's the area where aesthetically, because it's a hollow, the contour is very different. Whilst we can control what is happening laterally, I think the medial excess skin can become a real problem. And I'd love to know what you do, to control that, especially with the orbicularis trim and the skin redraping.
Well, yes, the medial canthus is the most complicated and one of the most beautiful areas of the face. And certainly orbicularis resection has to be very, very cautiously considered medially for many, many reasons. Most of my orbicularis resection is lateral or central, not so much medial. I think every patient is different. We just have to look at the framework of the face, bone structure, the brow position, eyelid skin tone. And then we've got, a palette of options that include resurfacing, chemical peels. Does the brow position need to be shifted, which will change medial canthal skin position? Do we need to fixate medially the crease to create more of a contour depression to drive the concavity further? Repositioning the medial fat. So I think it's hard to, and maybe this is what you're getting at. It's hard to have a single answer there because every patient has their own beautiful version of the medial canthus, and it's our job to respect it and have lots of creative tools in our tool chest to be able to try and offer improvements. But then, if we also need to understand what our limits are and what can't be done, and communicate that with patients, and to not violate the medial canthus aggressively when we don't have a definite plan.
That's a very broad. It was a very broad question and a very lovely umbrella coverage of it. But what is your preferred technique? Because all of us have something that we find is our workhorse that works well at that inner corner. What is your preferred technique, particularly for patients who are like 60, 70 and have a bit of a medial brow descent along with that medial fat pad?
So in contrast to what's going on in the UK, I guess I'm doing more endoscopic brow lifting. I think there are so many variations and subtleties on what it means to say endoscopic brow lifting, but it allows for elevation and control of the mechanical ptosis that exists from the brow position from above, being able to manage the glabellar musculature and the thicker brow skin and its relationship to the medial canthus, I think, is one important aspect that I utilize routinely for patients who have a low, heavy brow position that's affecting the medial canthus. And then, I do a lot of direct suture fixation to, the levator. Sometimes the levator fizzles out and there's nothing to attach to, but you'll find something to be able to drive your crease and control it medially. So I find that I use that quite a bit. And then I'll also have staged approaches where I'll tell patients, look, we're going to have to come back and do two things. First step will be blepharoplasty surgical surgery. And then later on, we may have to come and do some resurfacing to take care of some crepiness medially. Those are some of the techniques that I use.
Amazing. What I do is I do a lot of this fat repositioning. In fact, I think I talked about it in thyroid eye disease, and it was in a publication from 2010, where we noticed that the central fat pad in thyroid eye disease was deficient, and we were moving the medial fat pad. This is, many, many years ago. So often I find that if you reposition and give the fat a lovely drape for the creating that brow fat span upper lid fold. And then I do a very small orbicularis trim, being very careful not to extend it beyond the punctum. And then the fixation almost to the arcus, almost like a brassiere stitch, but a very, very soft brassiere stitch with just one throw of 7/0 vicryl to keep it in place so that it dissolves very quickly. But I find that sort of works for me in these challenging patients, and also setting the expectation bar for the patient as an 80 to 90% improvement, not 100% effacement of that glabellar hollow and prolapsed
I
fat.
agree with you, Sabrina. I think there's so much power in being able to mobilize and move the medial and central fat pad to our will to achieve contour shifts. And I think it's one of the most fascinating and fun aspects of doing upper blepharoplasty is that adjusting fat contours and volume. And actually, I wanted to maybe go back to Dr. Wu, if I might ask, and also Alice, if you have anything to comment regarding contour of the upper eyelid. I certainly do not do the kind of volume of Asian blepharoplasty that you do, but in some of the cases that I do, I find that subbrow volume loss and brow descent really creates a sulcus deformity in aged Asian eyelid configurations. How often do you find fat grafting or augmentation tools to be utilized, in that space? Or do you feel like mobilizing fat in the way Sabrina is describing has utility in your patients?
Wu, you would like to go first?
So if there is a fat, then fat mobilization is good. But for the patient who had very severe volume loss, like xalatan usage or some kind of very thin volume, then I would use the dermis fat graft onto the superior sulcus to fill that area. That is my technique.
Mm-hmm. I have a question. I spend a little bit of time in Korea, and I saw them doing a lot of fat grafting to the central forehead in the subperiosteal or pregaleal planes. Do you guys do that routinely in your practice?
No, not at all. That is very popular in very young female patient. They will just want very
Convex
prominent
forehead.
forehead. So I
Yeah,
don't
Deepak,
quite understand why they want that kind of volume.
Deepak, you are right. There's a paper in, I think it was the Facial Plastic Surgery Journal a few years back that demonstrated, brow lifting through central fat injections into the frontalis muscle. Is that what you're referring to?
Partly that, and also partly, I think the aesthetic, goals that might vary from culture to culture.
Definitely. I think the beauty standards in the West and the East are very, very different. So in the East, a lot of patients would, prefer a rounded, fuller face, so they look a little bit chubby, and that makes them look a lot more youthful. In contrast to the West, they like a very sculpted look. Now the buccal fat removal is very, very popular. They give you a really sleek, contour that really accentuates your cheekbones and all that, which is not quite popular in the East Asian population. So, to answer your question, Tanuj, these days for patients who have a bit of sulcus hollowness, I tend to avoid subtractive sort of blepharoplasty. I'm going to speak about this in IMCAS in Paris end of this month. I don't know, Sabrina, are you going to be there?
Yeah, I'll see you there.
Yeah,
Oh,
so
yeah.
I'm going to introduce a new technique whereby, I basically do not remove any more skin. Instead, I tuck in the skin to volumize the sulcus. So there are a lot of advantages to really preserve the skin. And I hope I have an opportunity to present that. And in patients who do not want to have any surgery per se, and I tend to use HA fillers to fill up the sulcus. I'm not an advocate for fat grafting around the lid, because I've seen a lot of issues, a lot of clumps and a lot of irregularities on the upper lid, which I find it really difficult to manage afterwards. So patients who are okay coming in on a yearly basis to just do some touch up on the sulcus. So I think HA filler is actually a very, very good alternative to correct that.
I'm just going to make a little comment about fat grafting, which I didn't touch on at the beginning, but in terms of embryological origin, the fat from the rest of the body is very different from orbital fat, and so the receptors on the orbital fat are different from the receptors in the rest of the body. So when we're grafting fat from the abdomen and elsewhere to the orbit, it can behave very differently to what orbital fat behaves. And so it was interesting to hear about the change in fat volume with menopause and with endocrine changes, because they will have different behaviors when it's injected into the face and to the orbit. And secondly, just to go on with what Sabrina was talking about, I think the medial canthus, that glabella hollow, is a beautiful area, but it's so easy to get very wrong. And, you know, from my experience and learning and seeing patients who've been referred to me with webs, one of the things it's always worth checking about with the patient that you're operating on is whether or not they wear heavy reading glasses. So I have seen a few people refer to me with webs where the extension of the incision has gone a bit too medially. Obviously, it's a curve. We're not cutting on a flat space. And so that little suture that you put down to the orbicularis is really important, or to actually fixate it somewhere medially, because if there is tension on the nose, the nasal bridge, due to heavy glasses, then that can pull the skin down. But that's just been some of the few things I've picked up along my journey to get here. So I thought that would be helpful to mention.
I do have one comment to that, Rachna. I think if you limit the amount of fat that you transfer, then you have, even if you have a 50% increase in fat over someone's life because they gained weight, if you have 2 cc's, going from 2 to 3 is not a huge change. And the way to limit the amount that you put in the first place is to treat the fat more gently, so that you are not looking at a 30% survival, but a 70-80% survival. But I agree with you. It is something to keep in mind.
Okay, guys, any other comments, questions from anyone? We still have 3 minutes.
Tanuj, can I just ask, how do you fixate your fat when you do your, fat redrape in the glabella area when you're, or bringing it down from the brow?
I actually use dissolving sutures, usually a gut suture. I believe that the fat is not very mobile, and wherever you put it, it'll adhere pretty quickly. So just a 6-0 gut suture is typical. One thing that your previous comments made me think of, and I wanted to mention, is that the medial fat pad can also be mobilized into the glabella. So there are ways to release the glabella, access and manipulate the corrugator muscles, and mobilize medial fat into that space as well. Analogous to transposition of lower blepharoplasty, it has to be very patient specific, but it's just one more tool that exists for working in the medial canthal area.
Excellent. I just wanted to add something about a suture fixation. I've been playing around with a suture called Stratifix, which one of my colleagues, Saj Tola, we do a cadaver lab in Manchester, was talking about, and that's for your lower lids. So when you do your fat redrape, fat transposition, so Stratifix is has got barbs. The suture is like monocryl, but it's braided, it's got barbs, and it really made my life very easy. So, this is something that I'm just going to look at in terms of how it's holding the fat, but then I don't have to call the patient back. For suture removal, you just put them in from the periosteum, hold them up to the skin, and the fat just stays in place because of these barbs. It's a very, very nice suture. It's called Stratifix. So just a tip for fixation.
On just along those lines of thinking, the things that I've been playing around with for fat fixation in the lower lid also include fibrin glue. I have access to that in my surgery center. I'm noticing actually good results with fibrin glue, but also one observation that I've made with fibrin glue is that I think that there is a little bit less postoperative inflammation. And if you look to the literature, fibrin glue does decrease or inhibit the natural inflammatory cascade. But combined with something that I do very frequently on all of my cases, I use 2 grams of tranexamic acid IV for just intraoperative hemostasis. The two seem to really, really potentiate each other. And some of my postoperative edema now just seems much better. Now, this is all anecdotal. I don't have, like a case study lined up to tell you the numbers on it, but this is just purely observational in the line of trying to say what new things that we're doing.
Okay, ladies and gentlemen, it's time to say thank you on behalf of AIOS and OPAI to each one of you for staying back late, waking up very early, and giving us all these pearls. Thank you so much, all the speakers as well as panelists. Look forward to having you all sometime very soon.
Thanks, everyone. Have a good night.
Thank you so much. Bye-bye.